voice down very much. Thank you very much for allowing me to participate in this conference. I've enjoyed it a lot. I'm going to talk about telemedicine projects that we've done over the last few years and how it fits into the world, in my opinion. As you know, there are about 15 million premature babies born each year, and the most affluent areas, there are 1.2 million preterm babies. They have access to neonatal intensive care units. Where ROP is problematic right now is in middle-income countries and low-income countries that have access to neonatal care. That's where the current epidemic of ROP is happening. This was from Hannah Glencoe in pediatric research a couple of years ago, and very important. You can see the larger the circle, the larger number of at-risk population. The dark blue quadrant there, triangle there, is the number of blind, and the lighter blue, the number of visually impaired. You can see there are huge burdens in high-income countries, but a relatively small triangle of blind, whereas in South Asia and East and Southeast Asia, the wedge of blind is much, much larger, and the number at risk is much larger. So what are the manpower demands for detection of serious ROP? The only one I know that really has looked at it carefully was Alistair Fielder in a study some 10, 12, almost 20 years ago now, I guess. 8,200 babies required 20,000 examinations to detect 360 babies. So you can see there's a huge disparity between the need and the number who actually need treatment. There are a number of previous studies using the RetCam, which is the primary game in town. And the important thing here is not the number, but the lower level of sensitivity. When you have sensitivity of 16, 70, 18, 81%, that is not acceptable for a potentially blinding disease. You can see these other studies have also had different outcome measures which they were using. There's real-world implementation of telemedicine here in India and Karnataka with Anand Dinakar and his work in Bangalore. They go to remote NICUs, they have trained technicians who call the doctor if the child needs to be evaluated or treated, and they upload the images for expert review. Birgit Lorenz in Germany, Darius Mashvegi in California, and David Weaver in Montana also have had telemedicine projects of various kinds that have been pretty successful. But I think there is a need for a shift from diagnostic examination to ROP screening. People used to say when I went into the nursery that I was doing screening. I am not. I'm doing a diagnostic exam and making determinations about treatment. Referral warranted is a term that Anna Els developed in the early 2000s, and I think it has great merit. You can see referral warranted hopefully identifies those at-risk infants who need an examination. And hopefully within that population, you'd have babies who need treatment. Over the last few years, we've conducted a study called ROP to evaluate the telemedicine system in a large sample of at-risk babies who need an eye examination. You can see we performed the study in the U.S. and Canada, 13 different NICU systems, and published the results a couple of years ago in JAMA Ophthalmology on the validity of the subjects. Our babies were all less than 1,250 grams. But the take-home message, for any session for that infant, we had a 97% sensitivity, which sounds fantastic, for detecting referral-warranted ROP, which is not treatment-warranted ROP, but ROP that needs to be evaluated by an ophthalmologist. Look again, however, at the sensitivity at 94% at the lower 95% confidence interval, and that means 1 in 20 you'd be missing if that is indeed the truth. So it's problematic. One of the really nice parts about it is the negative predictive value of 99.9%, which means that you're very unlikely you can very comfortably call an eye normal. When we looked at only those babies who required treatment, there were 162 in our sample of babies. The sensitivity went up to 98.2%, and the negative predictive value went up to 99.6%. So where do these efforts lead? Use of telemedicine potentially gives every hospital access to excellent ROP care. In the U.S., it may allow physicians to examine only those most at-risk babies. And in my system, many babies are transferred to me for evaluation for possible treatment. And I look and I'm not terribly concerned, and those babies become live-in inhabitants in my hospital for a number of weeks, inconveniencing the family and potentially the child. It will likely be most useful in level 2 nurseries in our area. In other regions of the world, if there's no coverage or only limited ROP expertise, I think it has great possibilities. And certainly in countries like Canada, Russia, with widely dispersed populations, it might have use. There's, however, a word of caution about the use of telemedicine in a paper published by Pearson Capone and various academies in the U.S. in pediatrics. Review of current literature for remote digital fundus imaging using telemedicine and risk management considerations. The current use of telemedicine outstrips its systematic evaluation. They need standardized, validated protocols, performance standards, and clinical and cost-effectiveness evaluations. We're doing that in EROP and have just published in Pediatrics a cost-effectiveness evaluation of it. But I do think that it's very important that we understand the limitations of both diagnostic examination, which has variability across clinicians, and telemedicine, which has the inability to detect all babies who have serious ROP. ROP prevention requires collaboration between our neonatal colleagues, nursing colleagues, hospital administrators, and us before we can adequately care for our population. I did want to put up the meeting in Jaipur, the 2016 joint conference that will be occurring in Jaipur in December. We'll be attending and look forward to participating. Thank you very much.